From Indian Journal of Anaesthesia, I, Dr. Reniki Sharma, will be presenting an article published in the December 2024 issue of Indian Journal of Anaesthesia. It is titled Efficacy of Local Anesthetic Peri-femoral Artery Injection Compared to Subcutaneous Infiltration in Combination with Femoral and Sciatic Nerve Blocks for Reducing Thigh Tourniquet-Induced Hypertension during lower limb surgery under general anesthesia, a randomized controlled double-blinded trial. Tourniquets are used in orthopedic surgeries to minimize blood loss, but they lead to tourniquet-induced hypertension characterized by increased sympathetic activity, elevated blood pressures, and intense pain. Sedatives and antihypertensive have been used to manage tourniquet-induced hypertension, but they are associated with side effects like hypotension, drowsiness, hypoxemia, nausea, and vomiting. Peripheral nerve blocks like femoral and sciatic nerve blocks have shown in efficacious in reducing intraoperative thigh tourniquet-induced hypertension compared to single peripheral nerve blocks. Blocking the perivascular plexus with femoral artery blocks along with peripheral nerve blocks has demonstrated significant reduction in this hypertension. So the study aimed to compare the efficacy of perifemoral arterial block with subcutaneous infiltration combined with femoral and sciatic nerve blocks in lowering tourniquet-induced hypertension. So the primary objective of this study was to compare the incidence of tourniquet-induced hypertension between the two groups. The secondary objective was to find out the intraoperative antihypertensive and opiate consumption and postoperative pain scores at thigh and surgical sites between the two groups. Institutional Ethical Committee approval was taken and the trial was registered in Thai Clinical Trials Registry. It was a single-center double-blinded RCT which included ASA 1 to 2 patients 18 to 65 years of age, more than 50 kg, undergoing lower limb surgery with a tourniquet inflation time of more than 90 minutes, difficult airway, known drug allergy, contraindications to study medications, and local anesthetic toxicity risk or persistent opioid use or uncontrolled hypertension patients were excluded from the study. A consent was obtained from all patients and they underwent detailed preoperative evaluation. They were block randomized into two groups. The group SI, where subcutaneous infiltration was given along with femoral and sciatic nerve block, and the group PFAB, where peri-femoral artery block was given along with femoral and sciatic nerve block. The patient's intraop anesthetist and outcome assessors were blinded, and the block was performed by an independent anesthesiologist with more than 5 years of experience in the block room. All the patients received fentanyl and midazolam before the peripheral nerve blocks, and the block was given using a 100 millimeter nerve stimulation needle. 20 ml of 0.25% bupivacaine was given in both the sciatic nerve block in the popliteal region and for the femoral nerve block in the under the fascia iliaca. In the PFAB group, a block needle was used to circumferentially inject 15 ml of 1% lignocaine with adrenaline around the femoral artery anteromedially and posterolaterally. In the SI group, 15 ml of 1% lignocaine with adrenaline was administered subcutaneously in the subinguinal area under the ultrasound guidance after the femoral nerve block. And GA was induced and a Procel LMA was inserted in all the patients, after which a thigh tourniquet was applied with a pressure of 250 to 320 millimeters of mercury based on the surgeon's preference. And once the patient was awake and responsive after the surgery, the LMA was removed. Tourniquet-induced hypertension was defined as a 30% increase in the systolic blood pressure from the baseline during tourniquet infection, with the baseline systolic blood pressure determined as the average of 3 measurements at 5-minute intervals pre-inflation. And if there was a tourniquet-induced hypertension, then it was managed with IV nicardipine 0.2 milligram and given up till 3 doses, after which fentanyl 25 microgram IV was given, followed by routine postoperative care. So the primary outcome was the incidence of intraoperative tourniquet-induced hypertension. The secondary outcomes was the intraoperative use of IV nicardipine and fentanyl, postoperative pain scores at thigh and surgical sites at 4, 8, 12, and 24 hours. The thigh circumference at preoperative, PACU, 12 and 24 hours postoperatively. PONV and dizziness was measured with an NRS of 0 to 100 at PACU and postoperative day 1. The incidence of nerve injury was noted, and if it was also noted if there was any prolonged sensory motor blockade. Sample size was based on a previous study at 80% power and 95% significance. It was found to be 26 per group. Adding 10% dropouts, 29 per group was taken to be the sample size, and a p-value of less than 0.05 was considered significant. So this is the consort diagram. After analysis, there were 27 patients in each group. The demographic characteristics between the two groups did not differ significantly. So this is the diagram showing the intraoperative tourniquet-induced hypertension. These are the two groups, and it shows that the systolic blood pressure did not differ significantly between the two groups. The incidence was same in both groups, that is 14 per group. The incidence of tourniquet-induced hypertension in patients with preoperative hypertension and without preoperative hypertension were also similar between the two groups. Secondary objectives in terms of intraoperative fentanyl use and nicardipine use at various time points did not differ significantly. The pain at thigh measured with NRS and at the surgical site again measured with NRS at various time points postoperatively did not differ. It was 0 in all the time points. The PONV score was 0 at all the time points in both the groups. The dizziness score was similar. The thigh circumference did not differ significantly between the two groups. So, adding peri-femoral artery block to femoral nerve block and sciatic nerve block did not significantly reduce the incidence of tourniquet-induced hypertension compared to subcutaneous infiltration during the lower limb surgeries. The intraoperative consumption of antihypertensive and opioid was comparable. Post-operative, the pain scores, the thigh circumference, and incidence of PONV and dizziness did not show any significant difference between the two groups. In this study, tourniquet-induced hypertension is potentially caused by a catecholamine surge leading to vasoconstriction, and the pain is linked to skin compression, nociceptor activation, and anaerobic metabolism. So it was hypothesized that blocking the perivascular plexus containing the sympathetic and vasomotor fibers could reduce the incidence of hypertension. But the results suggest that this was due to the systemic absorption of local anesthetic. The peri-femoral artery group reported a higher incidence of tourniquet-induced hypertension, but the subcutaneous infiltration group also showed comparable efficacy, which can be attributed to systematic lignocaine absorption. Also, this study highlighted the safety of the administered doses, as there was no systemic toxicity related to local anesthetic usage was observed. However, there were certain limitations. Standard femoral and sciatic nerve block may not adequately block the posterior thigh or the obturator nerve. So using advanced techniques like the proximal sciatic nerve block or adding a posterior femoral cutaneous nerve blocks could have benefited in this study. The study lacked comparison with femoral or sciatic nerve block alone, and the persistent tourniquet-induced hypertension, despite comprehensive nerve blockade, suggests alternative mechanism or incomplete inhibition of sympathetic fibers warranting further investigations. Thus, compared to subcutaneous infiltration, incorporating a peri-femoral artery block alongside ultrasound-guided femoral and popliteal sciatic nerve block did not result in clinically significant reduction in tourniquet-induced hypertension in patients undergoing lower limb surgery under general anesthesia. Thank you.